Thank you for joining us on another episode of the Diabetes Bio Podcast, a podcast for the Diabetes Journal, the flagship research publication of the American Diabetes Association. My name is Darlene Sandoval, and today I'm joined by my podcast co-host, Dr. Kevin Williams, as Dr. Kirk Habiger is traveling today, so we're missing out on his banter. But how are you doing, Kevin?
Doing pretty good. I know, right? I don't know if he's the thought leader or if he's an influencer now, right?
Yeah, that's right.
Jet setting all over the place.
That's right.
So
I
yeah,
feel
we
like
miss Kirk.
we should have just got him in from the plane. It would have been perfect.
Yeah, there should have been, right? But I guess if we want to hear his voice, we could always go to the on demand for the ADA scientific
That's
sessions and listen to
right.
his
That's
talk.
right.
Yeah, so we always have Kirk on demand there.
That's right. So it's well, I don't know about you, but I feel like it's been a pretty fun-filled summer of sports. We've got the mile world record being broken by Josh Kerr. That was pretty cool. I don't know if you saw
Yeah.
that or heard about it.
I heard a little bit about it. I didn't actually see it, but I mean, it's just phenomenal. I can't
Yeah.
imagine running that fast.
Yeah.
I wish,
And
we all wish.
what's crazy is he called his shot like a year ago. He said,
Mm.
I'm going for the mile world record next year. And then he put the plan in place and went for it. It's pretty crazy.
So if we just say that, could we do
Yeah.
it?
Yeah, exactly.
We could just make it happen.
And then there were some soccer games or some football
There were.
games in Texas, right? Did you make it
That's
to any
right.
of them?
I did not. They were pretty expensive. But
Yeah.
yeah, I think Argentina played here a couple times, and Portugal was here. It was they were flying around to different venues, playing the different levels of the matches, and they came back here from time to time. So yeah, there was a lot of excitement here. I definitely saw people at restaurants, dressed up. People were going out to bars.
Yeah.
The Fair Park here, which has the annual State Fair of Texas, they were having watch parties at the Fair Park.
Yeah.
So a
Yeah.
lot of people were going there and celebrating, and so it was nice to see. It was a cool experience.
Yeah. I mean, we had a lot, even though we didn't have any games here, we still had a lot of watch parties downtown and stuff. The city has one park that they had a big screen TV, and you'd have to reserve spots, but yeah, it was pretty cool to see everybody getting into it. And then of course we have the Tour de France, which is, I don't know how much you follow that. Certainly Kirk and I do. It's a little boring because Tadej Pogačar is just kind of running away with it, although it was a little bit of excitement and controversy this week with Jonas Vingegaard, the second place cyclist. He's won a previous two times, I think, crashing and having to go out of the Tour de France, but also was drug tested at 2 a.m. the night before.
Oh, wow. Yeah.
So yeah, a little bit of controversy there. Did he lose concentration because his sleep was interrupted?
Yeah.
Oh.
I haven't watched much of it, but I was at a conference in Barcelona 2 days after they left.
Fun.
And so I just missed their departure. That would have been pretty
Yeah.
cool to see. But there were
Yeah.
people that were at the conference that came in a few days ahead of time, and they were talking about how impressive it was to watch them go. And I do find myself at this time of the year, even though I don't watch much of it, doing a lot of my exercise on stationary bikes.
Yeah, for
Yeah,
sure.
just
For
to
sure.
pretend like I'm participating in some
Yeah.
way. But
Yeah.
so I've been doing that.
So if you're interested in cycling, NBC has on YouTube these like little 25-minute recaps. So it's kind of nice. That's how I've been watching it, is when I'm on the elliptical or doing my strength work, I just pop it on there and I have something to watch. And sometimes it's really exciting. The sprints are fun. So yeah, anyways, are there any other summer sports that you are spectating?
I haven't been spectating them. I did to go back to Barcelona when we were there. It was extremely hot.
Yeah.
And that's something that does not come across on the TV.
Yeah.
Of the weather, the climate that these cyclists are going through extreme challenges of what they're doing. And so putting their bodies through all of that, getting to the speeds and the times and everything that they're hitting in order to complete stages and finally win the
Yeah.
event. It's very impressive.
Yeah, it really is. That's a big reason why I like watching it, because it's just a pretty phenomenal display of physiology, right? The extremes of human physiology.
Absolutely.
All right. Well, I guess we should get to work. So today we have a bit of a special episode. Every year, the Diabetes Editorial Board puts together a symposium for the ADA scientific sessions. And this year's symposium was focused on diabetes complications. And we have three of the four presenters that we've interviewed today. We're hoping to get the fourth one for next month. So, Kevin, can you tell us a little bit about who we interviewed, their names, and the topic of their talk?
Absolutely. Yeah. We were lucky enough to sit down with some of the authors behind that work, and John Ussher discussed diabetic cardiomyopathy and how we might rethink the way the diabetic heart gets injured. Norbert Stefan talks about how diabetes links to MASLD or fatty liver disease and how it could be a complication of diabetes. And Julia Critchley is talking on the connection between diabetes and infection. These are sides of diabetes we don't talk about nearly enough. I should note, like Darlene mentioned, Lorraine Lipscomb is not able to join us this month, but her work was focusing on links between diabetes and cancer. Be sure to check out all of these discussions as you listen to the episode. But I will mention that all of their talks from the scientific sessions are available on demand now at ada.org. And every one of these authors has an article out this month in the Journal of Diabetes. So you can dive deeper into these subjects, whichever one you find interesting. But before you do any of that, definitely settle in for these conversations we have in this episode. I think they're truly fantastic and worth sticking around for.
That's right. These interviews are a bit of a preamble for the articles that you will read in the journal. All right, let's jump in.
We're starting our discussion today with the heart. Our first guest is Dr. John Ussher of the University of Alberta, whose work sits at the intersection of cardiac metabolism and diabetes. His work has also helped define how diabetes changes the way the heart fuels itself. His talk at the American Diabetes Association scientific sessions in New Orleans suggested that we should refine or rethink our understanding of diabetic cardiomyopathy, and he expanded that case in a companion article for the Journal of Diabetes that's out this month. We're delighted to have him here to discuss more on this topic. John, welcome to Sweet Talk.
Thank you, Kevin, for inviting me to be here with you, Kirk and Darlene. Very excited to be talking about this topic with all of you today.
Now, before we get into the science discussion, we always like to start off with a little bit of an icebreaker. And the question I have for you today, if you had not become a scientist, what do you think you would be doing right now?
So I guess the way I'd frame this, so I'll have two answers here. But in like dream world, if I could have been anything other than a scientist, and as we kind of started, as we were getting set up, we had a conversation about the Edmonton Oilers, and so I grew up loving hockey. I would have loved to play hockey when I was growing up. It's just such a
Nice.
fun sport. But you guys have seen me visually. I'm petite, 5'4". So so hockey would never be an option for me. So more realistically, what I would have loved to do, actually, and we talk, even though I don't normally like listen to podcasts, I love watching, YouTube and looking at, watching First Take and Undisputed and, being a
Yeah.
commentator or analyst, just debating sports, to get paid millions of dollars to do that. I would have loved to do that. And so, it's funny when we were at ADA, just, in June, I had just met John Buse for the first time. And one of the first things he said to me is like, "You sound like you could have been a commentator on sports." And I was like, "I would have loved to do that." And so it's, yeah. So, but here I am as a scientist today, and very happy though that is what I do. So,
There's still time.
yeah. Well, anyone can go on YouTube these days and just, make their own take on a sport, right? So I guess maybe in my free time I'll try and make some time.
All
Awesome.
right, I have the first question, and let's just kind of dig right into some basics. So tell us a little bit about what diabetic cardiomyopathy is and why it's important in terms of ventricular dysfunction and how that relates to, whether there is hypertension or not and coronary artery disease and the implications for people with diabetes.
Yeah, so just to start, so I guess the kind of simplest, or I say like the historical definition for diabetic cardiomyopathy, if you read a review article or a textbook, is most commonly defined as ventricular dysfunction or cardiac dysfunction in the absence of traditional macrovascular diseases like your hypertension or coronary disease, atherosclerosis, in a person living with diabetes. So I'd say that that's like the historical definition, and what I would argue is probably, though, a really poor definition, simply because especially when you talk with clinical individuals, cardiologists per se, it's just often people with especially type 2 diabetes, because it's often driven by underlying obesity. It's you don't have many individuals that aren't at risk of these kind of traditional cardiovascular risk factors like dyslipidemia, that will have hypertension. That the argument often would be, and even when I started my program nearly 12 years ago, was that it's not really a prevalent condition, a diabetic cardiomyopathy, because people that have had diabetes for 10 or 20 years, what's the actual population of those individuals that don't have some macrovascular, cardiovascular risk or hypertension. And so that was a common kind of criticism that I faced. But I think, the symposium article that I had put together, I think one of the real issues is that it's just how we define diabetic cardiomyopathy today based on historical findings from clinical studies done in the 70s, is just not really, in my opinion, appropriate, and why I believe that we should really think about redefining or reframing the context of this disorder.
So let's dig in a little deeper. What is the evidence that supports the idea that diabetes directly impacts the myocardium?
At least from the studies that have actually explored it. And so, when you actually remove those traditional risk factors and just like look at someone having diabetes, that while you won't often see major systolic dysfunction in a person with diabetes, in the absence of these traditional, more common cardiovascular risk factors, that I would argue that there's more evidence supporting, though, that these individuals may have diastolic dysfunction. And part of the focus of the symposium article that we had put out was that diastolic function or diastolic dysfunction is really more the predominant defining feature of what diabetic cardiomyopathy should be.
So I guess that leads nicely into my question, which is, what is diastolic dysfunction? How can someone with a normal ejection fraction still have meaningful cardiac dysfunction?
Yeah, so I guess the way I would frame this is, so when we think about, and I guess I'll kind of explain this more kind of in layman terms concepts, but like when we think about heart function, I think most people will view the heart as your organ that its responsibility is to beat, contract, pump blood to the rest of your body so that you can survive and do like your daily activities, right? But between each contraction of the heart has to relax before the next pump. And often we don't think about heart function as the function of the relaxation component. And so diastolic function or diastolic dysfunction really deals with how the heart relaxes and the potential problems that the heart may have when it relaxes between pumps. And so to answer then your second question, when we talk about traditional ejection fraction and having meaningful cardiac dysfunction, even though you have a normal ejection fraction, I guess the challenges here become that is, I guess, and I just want to make sure I frame this properly, but is the cardiac dysfunction is meaningful, but it may not seem meaningful on the surface to someone like, like the person living with the disorder, because for most part, diastolic dysfunction, especially in the context of diabetic cardiomyopathy, is going to be asymptomatic, subclinical, because their heart is still beating properly, it's contracting properly, and so they don't realize that between each of those pumps that their heart actually has an underlying issue going on. And I guess just to expand further, I think where this becomes potentially a real concern, specifically in people living with diabetes is also a major risk factor for heart failure itself. And we now know that there are two forms of heart failure. And so kind of, again, classic heart failure is failure of the heart to pump blood properly to the rest of the body, which is, is your systolic dysfunction known as heart failure with reduced ejection fraction. But I'd say, it's become a lot more prominent, our understanding in the 21st century, that there's also heart failure with preserved ejection fraction, or HFpEF. And that's heart failure where more relates to issues with how the heart relaxes. So the heart still pumps blood properly, and often, initial stages of HFpEF heart failure with preserved ejection fraction are often also going to be asymptomatic because it's this diastolic dysfunction. But as I was saying earlier, in the context of diabetes, I think this is very important because our clinical evidence today actually suggests that heart failure with preserved ejection fraction is now the more prevalent form of heart failure in people living with diabetes. And so then when we go back to this concept of redefining diabetic cardiomyopathy and focusing more on the diastolic dysfunction in diabetic cardiomyopathy, we believe it's very important consideration because, and what we don't have clinical evidence for, but what we believe will be really important to do in the future is to actually, kind of figure out what the true prevalence of diastolic dysfunction is in a person living with diabetes, again, in the absence of these more traditional cardiovascular risk factors or macrovascular cardiovascular disease. And if we can identify what that actual true prevalence may be, is then trying to determine whether someone having diastolic dysfunction, diabetic cardiomyopathy, if you actually leave this unmanaged, and often, again, it's asymptomatic, it's silent disease, people may not realize they have it. But if you leave it unmanaged, what is the actual kind of prognosis for that person eventually becoming someone with diabetic cardiomyopathy that eventually becomes a person living with diabetes that develops heart failure with preserved ejection fraction? And if there are clear connections between that, then I think the argument would be that we should be screening people with diabetes much earlier for their diastolic function. And if they have diastolic dysfunction, that you would actively want to treat and manage that much earlier than what we're currently doing. Because if you can actually treat and manage early and prevent a person from developing heart failure with preserved ejection fraction, I actually think the relief on the burden to the healthcare system for managing heart failure, I think that would actually be pretty relevant and impactful. And so, and it's part of the reason why at least our lab is just very interested in trying to learn more and understand more about the pathogenesis of diabetic cardiomyopathy.
John, you need an echo to diagnosis. Is that correct?
So echo in community, like community practice, real world practice, would be the most common way to do it. Like the technological advancements in ultrasound echocardiography have made it that we can detect diastolic dysfunction much better with echo.
Okay.
Gold standard, though, still is cardiac magnetic resonance imaging or cardiac MRI. But that's really refined to academic, hospital environments. It's the overall sensitivity for detecting diastolic dysfunction is going to be much superior with cardiac MR, but it's just the whether this would ever make its way into real community practices. I know I'm not a clinician, so I don't want to say for certain, but I think it's much more unlikely that you'd see that routinely being used.
I was just curious whether that's part of the uphill battle in terms of screening people, especially if they're asymptomatic.
Yeah, so I guess I definitely contributes, and I think the other kind of underlying issue here is just, at least when I talk to a lot of my endocrinologist friends, or and for most part, even it's not even endocrinologist, but like first point of care contact for someone with newly diagnosed type 2 diabetes is going to be your primary care physician, your family doctor. And I think, conversations at that stage for someone, in the first year of their diabetes are going to be like, oh, usually it's probably, for most people going to be a little driven by, overweight or living with obesity. And so conversation will be like, can you implement some exercise or nutritional dieting into your life and have those lifestyle interventions to lower your blood sugar, cause some weight loss? The physician is not wanting to write a requisition form to send you to the imaging center, to do an echo and see what your diastolic function is. And so I guess, the argument I would make, though, and what I think is really important is that even though that's not what the focus of management is, I think it'd be really important at some point for, I would hope that someone with lots of enthusiasm and energy would want to do those clinical studies for us to figure out what that prevalence is. Because I think if we could actually really determine what that prevalence is and how likely someone who doesn't have traditional cardiovascular risk factors or risk for macrovascular or cardiovascular disease, but if we just knew, even if it was 30 or 40% of the population with diastolic dysfunction in the first, year or 2 years of having newly diagnosed type 2 diabetes, I think that would still make the case where we should maybe consider sending more of these individuals, to the imaging center early on to see what their diastolic function is, because of the potential long-term implications, for maybe being a risk factor for future heart failure, preserved ejection fraction, HFpEF development. And I guess even more excitingly, and something I've got asked a lot in the last 6 months, and even was asked during my talk at the ADA, was, are there biomarkers for diastolic dysfunction? And and it's got me thinking about writing a grant, to see if we can try and figure out what a good biomarker for diastolic dysfunction might be. And maybe that could be the impetus, the stimulus for a primary care physician, if someone had that biomarker, that then those would be the people you'd want to send to kind of verify that they have diastolic dysfunction or not.
Yeah, and I was thinking about that biomarker question as well, and it kind of gets maybe at the heart of the research that you're actually doing, trying to understand the mechanism within the tissue, within the cells, what might be changing in a diabetic heart and how it's being fueled. I think there's, correct me if I'm wrong, there might be a shift towards fatty acids away from glucose. And I was wondering if you could walk us through that process and that shift, why it might lead to a stiffer heart, one that might be slower to relax between beats. And maybe, as you're talking about biomarkers, maybe there's a combination of readouts there that you might be able to kind of formulate for a hypothesis. And so just curious about that.
Yeah, fantastic question. And so I guess in terms of the metabolic shift, I think we have pretty convincing evidence now from both, preclinical studies in animals and now human studies using either PET imaging or hyperpolarized, carbon-13 NMR, that someone with not just type 2 diabetes or even type 1 diabetes, but also obesity itself, that the heart does indeed undergo a metabolic shift where it's predominantly, meeting its energy needs by oxidizing fatty acids. And this comes at the expense of a robust impairment in the oxidation of carbohydrates like glucose. So this shift, though, is and there's a lot of explanations for it. One of them is simply insulin resistance. Again, in someone with obesity, type 2 diabetes, insulin stimulates glucose metabolism. You have an insulin resistant heart. And then you also have the dyslipidemia that often characterizes obesity, that just, there's more fat being delivered to the heart, and the heart's an omnivore that oxidizes whatever it sees because it has, on a per gram basis, the highest metabolic demand in the body. And so, yeah, it's just when you combine those factors, heart is going to use up a ton of fatty acid as its primary fuel source. And so we've done a lot of work in our lab, primarily again in preclinical studies, is to show that if you actually correct this metabolic switch in diabetes and increase the amount of carbohydrate that the heart oxidizes as a fuel source, that actually can lead to restoration of diastolic function in diabetic cardiomyopathy. But then to the last part of your question, though, in terms of understanding like the mechanism, this is where, like, we are very interested, actively pursuing, but don't really have any good answer right now for, like, why would shifting fuel use from fat to carbohydrate actually allow the heart to relax better, between contraction. The traditional view of energetics in the heart was that when you switch to glucose as an oxidative fuel source, it's a more oxygen efficient fuel in terms of ATP production per oxygen consumed. And the argument for that, though, would be primarily driven towards improving systolic function, that the heart can contract better because it's making more ATP per oxygen consumed. But then, when we talk about diabetic cardiomyopathy, as I've mentioned, this is really a problem of diastolic dysfunction. Systolic function, for most part, is normal. And so it doesn't really, the traditional view of why using carbohydrate, why it's a better fuel source for the heart, I don't think is compatible with, like, that mechanism is not compatible with diabetic cardiomyopathy and diastolic function. But what I think is really important, what we're very interested in now, is like diastole itself. When the heart relaxes, that's still a very ATP energy dependent process. And so there might still be efficiency issues at play when you switch what fuel you're using that can actually help the heart relax better. And so that's some of what we're trying to study now and trying to see if we can kind of figure out in the lab.
That's really cool. One of my faculty members is studying heart failure, and so that switch in metabolism I think is really interesting. So it sounds like at least from what I understand, diastolic dysfunction can also occur in type 1 diabetes. I know you mentioned obesity being a risk factor, but if it also occurs in type 1 diabetes, what are the commonalities there, or are there, or is it just happenstance that we have these two diabetic diseases that drive the same dysfunction?
Yeah, no, thank you. Fantastic question. And you're absolutely correct. So, like, in type 1, at least the evidence we have both preclinically and clinically is that in type 1 diabetes as well, you can have people with diastolic dysfunction too. And so when I think about commonalities between the two, so, it's one of the things we don't know is it a universal diastolic dysfunction, diabetic cardiomyopathy, or is there a unique diabetic cardiomyopathy for people with type 1 diabetes versus those with type 2? We don't have a good answer on that. But I would say in terms of potential commonalities and I'm going to go back to what I just discussed on cardiac substrate metabolism, in type 1 diabetes, where you don't have that insulin action because you're not making insulin and secreting insulin, is the heart in type 1 diabetes also is characterized by, this robust increase in fatty acid utilization. You're not oxidizing carbohydrates. And so this is some of the research that we've been doing is just to actually link that having impaired glucose oxidation. So we've been focusing more on the carbohydrate than the fat. But there is evidence now from our lab and others that show that if you just have an impairment in glucose oxidation, that is sufficient to cause diastolic dysfunction. And so and that's why we really think that the energetics is a really key mechanism at play here. And so in that sense, that there may be kind of, again, I don't want to say for certain because it's such a diabetes is so heterogeneous, but I think for a lot of people with type 1 and type 2 diabetes, that the impairments in glucose oxidation are an underlying mediator that likely play, like, if they're not like, the major mediator, but I think regardless will play an important role in why these individuals might have this underlying diastolic dysfunction.
A follow-up question that wasn't on the script, but I'm sure you'll have some answer for it.
No worries,
My
no worries. I love going off script.
My recollection is that women with heart failure, have more of the preserved ejection fraction version than men. And so, is there a sex difference here in terms of diastolic dysfunction, or do we not know enough about the incidence to understand that?
So you're correct in that HFpEF is like being female is a risk factor for HFpEF. And so in the context of type 2 diabetes or diabetes, so what I don't know, so women with diabetes, their relative risk for then developing cardiovascular disease is greater than if a male then gets diabetes, their relative risk. But the actual absolute risk, I think, is pretty similar. And I don't know, though, the answer in the context of diabetic cardiomyopathy per se. But again, just thinking about like HFpEF being more prevalent in females, and the relative risk for cardiovascular disease being greater in a female who gets diabetes. I think this is a really important question. But one of the challenges is that at least the predominant preclinical model for studying diabetic cardiomyopathy does not really induce the phenotype in female animals. So it's like really easy to study the disease in male animal models, but it doesn't work well in female animals unless they've been ovariectomized. So and also being postmenopause in women does also lead to further relative increases in relative risk for cardiovascular diseases. So I think there's a lot of really important questions there that need to be answered.
Thanks.
So, John, we discussed that the historical definition of diabetic cardiomyopathy is probably incomplete. So, if you had a chance to rename this or redefine it, how would you do so?
Yeah, so I guess I'll give two answers here. So the first one is, if we were to actually rename what the term of the pathology. So my PhD mentor and lifelong friend, unfortunately, he passed away last year, but the late Gary Lopischuk, in the conversations we had, one of the arguments he would often have with me is maybe we call it metabolic cardiomyopathy instead of diabetic cardiomyopathy. And I could see a good argument for that being the case. I think that for most part, like again, when we think that the changes in metabolism can mediate the diastolic dysfunction, that I would not be against that. But if we were to stick with the term diabetic cardiomyopathy, now what I would just like to frame at the beginning of my statement here is, I'm not so fully comfortable being the one to say what the new definition should be, simply because I'm, a basic scientist using preclinical models and not a physician. That I don't think that I should be the individual that harbors the power to redefine a pathology. But what I do feel comfortable saying, and what I think is really important, is that whatever and this is where I think stakeholders, again, like ADA, AHA, cardiologists, and I think they have to come together and think about coming to a consensus on how we define this. What I would feel most comfortable saying is, I just feel like diastolic dysfunction has to be the predominant feature, at least pathologically, in terms of this is what most of these individuals, and again, I don't want to say all individuals, because diabetes is so heterogeneous. Diabetic cardiomyopathy is going to be heterogeneous by nature of diabetes being heterogeneous. But it's just going to be I think it's the most important pathological feature, that I think it's what the focus of whatever new definition should be. But I think there still needs to be other components to that. I mean, my argument, what I've pushed, is that it's diastolic dysfunction in the absence of traditional cardiovascular risk factors and macrovascular cardiovascular disease in a person living with diabetes. But I think that still doesn't cover everything. And so that's why I think, I think there's still room for more refinement beyond what I've proposed. But I think as long as diastolic dysfunction is there, that I think we've made a big improvement versus what we currently have today.
Great, thanks.
Yeah, John, that was fantastic. And, we as scientists, we definitely like our acronyms and our abbreviations. And I definitely appreciate how you went through the definitions without saying HFpEF, HFrEF, and all these other acronyms. Really cleared up a lot of the jargon. So it's a really great discussion. Thank you for helping us to understand why diastolic dysfunction may be the key to defining diabetic cardiomyopathy, and why identifying it early could matter for preventing future heart failure. For our listeners who would like to learn more, John's article with Alexa King is titled "Focusing on Diastolic Dysfunction to Achieve Consensus with the Term Diabetic Cardiomyopathy," It's available in this month's issue of Diabetes as part of the 2026 Diabetes Symposium collection, and you can view John's talk from the ADA scientific session streaming now on demand. John, thanks so much for joining us.
Thank you for having me. It was a pleasure.
Dr. Norbert Stefan has spent a lot of his career on a question that sounds simple but isn't. What is fat in the liver actually doing there? He's an endocrinologist at the University Hospital in Tübingen, Germany. At the ADA scientific sessions in New Orleans, he suggested that MASLD deserves to be thought of as a complication of diabetes in its own right. And he lays that out in more detail in his article in this month's Journal of Diabetes. We're really glad to have him join us and discuss more of this in detail. Norbert, welcome to Sweet Talk.
Thank you very much, Kevin.
Before we get into the science, we always start off with a little icebreaker question. And so I was curious, when you look back at your career, was there a moment when you realized being a clinician or a scientist studying liver metabolism was going to be your home in science?
Yes, thinking about this, actually, there are 3 time points in my scientific career where the liver got into the focus of my research. First was when I was a fellow at the NIH, working in Phoenix with Hema Indian, now called Totem population. The population having actually the unfortunately highest risk of diabetes worldwide. And in those days, in 2002, with colleagues, I established the whole body imaging of adipose tissue mass distribution, and then also liver size and liver lipid accumulation. And it was interesting to see those days that the liver lipid accumulation was the strongest determinants, correlates those days with high glucose and insulin resistance. So this was an observation. And then in 2006, I did studies with colleagues in mice, but also clinical data were observed that when lipids accumulate in hepatocytes, there is an increase of certain proteins that are being released into the circulation. And one of the protein I'm most interested is fedouin A. And our data, and then from other colleagues, we could show that this protein being upregulated and secreted when there is increased ORC1 signaling and via fatty acids and glucose, that this protein induces inflammation in adipocytes, endothelial cells. And so actually I coined the term hepatokines in analogy to adipokines that we were researching before. And the third and more clinical aspect was about 2018 when I did clinical studies and realized more and more that it's not only the obese people who actually can get severe steatotic liver disease with inflammation, but very lean people. So observation that we then published in Annals of Internal Medicine, where a young female actually got severe adipose tissue inflammation based on checkpoint inhibitors, and she developed complete lipodystrophy, and it was all related to adipose tissue inflammation. And what happened is that she developed the highest steatosis I ever saw among my 2,000 people with fatty liver measurements. So that resulted in that the steatotic liver disease, and she actually had triglycerides about 4,000 milligram per deciliter, severe diabetes. So the liver was actually a promoter of the metabolic diseases. And finally, a very unexpected treatment resulted that she could be cured. And it was the pioglitazone that many of us well know as a drug that improves adipose tissue, subcutaneous adipose tissue lipid uptake reduces inflammation. So these escalating encounters that I had with steatotic liver disease really told me that proved that research into steatotic liver diseases is important.
Yeah, I love that background of the true clinician scientist, the clinic informing or directing hypotheses and questions back to the benchtop, and then the benchtop experiments, trying to explain what's happening in the clinic and back and forth. I love that history to your scientific career.
So, Norbert, you were a part of the multidisciplinary Delphi consensus process that moved the field from calling it NAFLD to MASLD, MASLD. So, tell us a little bit about why that shift was important and what the thought processes were into making the terminology change.
Mm-hmm. Yes, this change in the terminology and in the diagnostic procedure that we published in 2023 was actually based on the point that in the clinical aspect research, we observed that it was very difficult to address the steatotic liver disease when we always starting with the problem of alcohol intake. Certainly, sitting up, having a patient in front of you and talking about steatotic liver disease, we need to come at the very end sometimes to the point of asking about alcohol intake, because we know that the high alcohol intake induces steatosis strongly, and we have a treatment for that, really addressing alcohol intake. But for many of our patients, it was like a discrimination when the first question is, we're talking about non-alcoholic fatty liver disease, so how much is your steatosis really related to alcohol? And the hepatologist who led actually this Delphi consensus were the ones who said, yes, this is what we really have a problem, and our patients feel uncomfortable addressing, is it alcohol or not alcohol? And the second part was that the hepatologist really learned from us endocrinologists about the strong relationship between the steatosis that is not alcohol related, and where certainly other diseases that specifically induce hepatic steatosis, like glucocorticoid treatment, like hypobeta-lipoproteinemia, where morbus Wilson, so very rare diseases when you need to exclude them, but the largest variability, about 85% of the steatosis, is then really related to the metabolic environment. So these two these major points resulted that we decided to rename it, to leave out the point non-alcoholic and have it as a additional aspect called MASLD with increased alcohol intake. So that's extension of the steatotic liver disease. Then the point was that at least one cardiometabolic risk parameters, mostly related to what we know about the metabolic syndrome, should be there, and obesity, overweight as well. So the terminology moving away from this discriminatory or point of alcohol and focusing more on the metabolic problems resulted in that the term metabolic dysfunction associated steatotic liver disease was coined, and this always was decision and that it is relevant, and it is very well now recognized also by other people just starting research in MASLD.
Yeah, I was going to say it feels like a really important turning point in studying fat in the liver. And how do you feel? How has it been perceived by clinicians, sort of in the real world, and patients?
It was easier to communicate with the patients
Yeah,
because not putting the alcohol
yeah,
point up front. And it actually got more diabetologists, endocrinologists, but also general practitioners in the field, because they said, okay, it's easy to identify steatosis. So the general ultrasound, abdominal ultrasound, is actually what you can detect within 1-2 minutes. Then you have some metabolic risk parameters you need to account. So therefore, it was much more easier and convenient for a broad group of physicians, not experts in hepatology, to start looking into this field. But certainly one thing should not be forgotten, and this terminology doesn't change the point that it still needs to be there. So we need to look on other liver diseases that need to really to be treated differently. We need to talk about hemochromatosis that is not that seldom. We need to talk about viral hepatitis that is still a problem, particularly more in the Asian countries. And at the very end, certainly, we should not completely stop thinking about the alcohol intake. So
Yeah.
it became more convenient now working with this definition. But on the other hand, certainly we need to have this clinical view to exclude the other conditions as well.
Yeah, and I think this builds right into the symposium, the journal, the Diabetes Symposium that was held at the American Diabetes Association Scientific Conference. It really focused on non-classical complications of diabetes. And you were suggesting that MASLD is included in these non-classical complications. And so for our audience, maybe you can lay out, why has MASLD historically fallen outside of that traditional list? And what is the evidence now that supports considering a complication rather than simply a common comorbidity?
Yes, I think it's an important point, and it's, as a diabetologist, we or as a student, we learned that the typical complications of diabetes are related to glucotoxicity. So on the kidneys, the nephrons, on the neurons, on the endothelial cells, so all related to, in most cases, hypoglycemia. So what we call microvascular and macrovascular complications. Now, the macrovascular complications we know are in diabetes are not only related to hyperglycemia and glucose toxicity, but certainly also to dyslipidemia. So the observation that among the classical complications, there is also a part related not only to high glucose, but to what we call or find with the metabolic syndrome, where we talk about dyslipidemia and inflammation, so different from hyperglycemia, resulted that in the clinical endocrinology and diabetology, we started looking on other complications that people with type 2 diabetes develop. And one of the complications that actually turned out to be forgotten or not present in people with diabetes before MASLD has come on the table is the metabolic related cancer. So metabolic related cancer is also not considered a classical complication of diabetes, but we all know that the milieu in people with diabetes, not only type 2, but also in type 1 diabetes with the hyperglycemia, promoting tumor growth, Warburg effect, the high lipids palmitate signaling that promotes metastasis of solid tumors. So we have the hyperglycemia, we have the dyslipidemia, we have the subclinical inflammation, and this is why the metabolic associated cancer should certainly be also considered as a complication. Now, this is actually this led also then to the field, to the observation that MASLD may be another new complication. And I really want to put it behind the cancer, because the cancer observation as a complication of diabetes, this is out there since 15 years. But until the last 3-4 years, it was really recognized as a complication, meaning that the screening for cancer, people with diabetes, should be really on the high list of cancer screening. Now, coming back and knowing that inflammation, dyslipidemia also is related to complications of diabetes, the observation was that the highest prevalence of MASLD, and particularly MASH and fibrosis among different diseases is being found in people with diabetes, and here specifically type 2 diabetes. So about now, in the adult population, about 70% of people with diabetes, in most cases type 2, have already MASLD. Up to 40% of people with type 2 diabetes have MASH, and up to 20% of people with diabetes have advanced fibrosis. So just this observation of this correlation puts, before talking about mechanisms, puts MASLD as a complication of diabetes.
So what comes first in terms of, is it fat in the liver or diabetes? So what happens in the pre-diabetes population in terms of incidence?
Mhm. That's an important point, because exactly here is where we can start looking to what extent hyperglycemia drives steatosis and to what extent it is independent of that. In people with pre-diabetes, so not strongly elevated glucose, the prevalence of MASLD can be about around 30 to 40%. And when we go to the overweight and obese, it can go up to 50%. So MASLD is already present in pre-diabetes. The idea or the hypothesis here is that the glucose that increases with, for example, skeletal muscle insulin resistance, subclinical inflammation, glucose increases because of a starting decline in beta cell function. Glucose upregulates genes of hepatic de novo lipogenesis very strongly. PrEP beta, for example. So the hyperglycemia is not only a fuel, but is also a driver of gene expression of generating lipids in the hepatocytes. Therefore, in prediabetes already, steatosis starts. The glucose increase is certainly a problem promoting steatosis. But two examples why it's not only hyperglycemia. And one is that the most important lipid-related polymorphisms in genes are associated with lipid droplet formation in hepatocytes in lipolysis, meaning the polymorphisms in PNPLA3 and TM6SF2. These are mutations that inhibit lipolysis in adipose tissue, in hepatocytes, and the VLDL secretion. So these are the most important pathways. So in these people having these mutations, they don't need to be hyperglycemic, they don't need to be insulin resistant, but they can develop a steatotic liver disease in a complete metabolically healthy stage. So therefore, we have a MASLD that is related simply to problem of lipid release from liver and lipolysis and safe mobilization of lipids. And the second part is where glucose is not relevant. This was this patient I talked about, a patient with severe subclinical adipose tissue inflammation. She developed lipodystrophy based on checkpoint inhibitors as a side effect. She got subclinical inflammation. You can develop of colitis, hepatitis, but you can also develop, some people can develop subclinical inflammation adipose tissue. So what happened here is that adipose tissue got completely inflamed. We proved that with biopsy. She was non-diabetic, no hyperglycemia at all. And this start of adipose inflammation resulted in the drainage of lipids. So no, the subcutaneous adipose tissue was not able to keep the lipids in place. And so the lipids were released in the blood, and she developed severe hepatic steatosis. So these are two examples where there is a dissociation. So therefore, I think there are three major pathways how you end up in the same hepatic lipid content, and in most cases, a very similar inflammation. One is lipid droplet formation, lipid droplet release, not related to metabolic syndrome. Lipodystrophy, where it can start with impaired lipid storage. And the third is that certainly the most common is high glucose. So we talk about diabetes, high fructose intake, high saturated fatty acid intake, where de novo lipogenesis is increased.
And I think through this discussion, we're skirting around standards of care. You know, if MASLD is now considered a complication of diabetes, what should the routine screening look like in diabetes care? Should everyone with type 1, type 2 diabetes be assessed? Are there specific high risk groups that should be screened? How should that be approached in the clinic?
The medical guidelines led by hepatologists in the US, in Europe, and also in the Asian countries, South America, recommend screening every patient with diabetes, independent type 1 or type 2, should be screened for MASLD. The next is obese people should be screened independent of diabetes, and people where the metabolic syndrome is considered present. So they don't need to have obesity, they don't need to be obese, but they have, for example, dyslipidemia and hypertension. So that already puts them at the high risk. So these are the three major diabetes, obesity, and metabolic syndrome conditions. So these people should be screened, and the guidelines recommend the screening with the fibrosis 4 score. So that is the most easily usable test, ALT, AST, platelets, and age. And if people are in a range of higher than 1.3 and lower 2.67, then they are have already an increased risk. So they should be evaluated either by the same physician doing a retest or already referred to hepatologists, and those with higher than 2.67, they should immediately be assessed by a specialist.
So that's a perfect segue, going from screening to treatment. So how much do you think we should be using? So of course the GLP-1s are going to benefit weight loss. And of course that has all of those other additional benefits across other organs. SGLT2 inhibitors have certainly been suggested to benefit the liver. What do you think about those particular strategies? When should they be utilized versus maybe the more liver-centric up-and-coming strategies, the FGF21 targeted therapies?
When a patient has type 2 diabetes, it's actually the easiest way of treat MASLD. Let's start with the easy aspect. And here, the starting point would be SGLT2 inhibitors. So SGLT2 inhibitors have always shown in people with type 2 diabetes that they can reduce hepatic steatosis, and it was indication that they can also reduce liver enzymes. Now there was a study published last year where people with MASH and fibrosis were randomized to SGLT2 inhibitors or placebo, and the effect was that this was the first study, the Dean study, showing that with the same setting as we test the classical MASLD related pharmacotherapy. So in people with MASLD, about 50% of them had type 2 diabetes, the others didn't have type 2 diabetes. Dapagliflozin SGLT2 inhibitor was effective in reducing inflammation, so resolution of MASH, and reduction in fibrosis was present. So this was actually unexpected. People thought that there might be a beneficial effect, but now it was proven. So SGLT2 inhibitors, although not yet approved specific for MASLD, showed that in a phase 3 study already, they could reduce or improve MASH and fibrosis. So the easy SGLT2 inhibitors now turned out to be mega effective. Now, in people with type 2 diabetes where hypoglycemia is prevalent, you may expect that the effects are even stronger. This has not been yet analyzed, but there are studies going on to do this. So SGLT2 inhibitors in patients with type 2 diabetes and MASLD MASH, I suggest should be one of the top first-line treatments. Now, if I wouldn't leave it with SGLT2 alone, because knowing that these people with type 2 diabetes also have an increased risk of atherothrombotic problems. So SGLT2 inhibitors are very effective to treat heart failure, but they don't have no effect on atherothrombotics. So therefore, what we do in our patients with type 2 diabetes, we add SGLT2 inhibitors on top of metformin, but also, if possible, GLP-based therapies. So with GLP-based therapies, we reduce the atherothrombotic aspect, so myocardial infarction and stroke, and we reduce fat mass. That is also important to being protective of cancer. That's not related with SGLT2 inhibitors. So we have a protective effect on atherothrombosis. We have a protective effect on cancer in these patients. And we know now semaglutide being approved in the US and Europe, specifically for MASLD treatment. Our patients anyway with type 2 diabetes profit from these drugs. So for people with type 2 diabetes and MASH and fibrosis, I would not even go at the moment to more severe or more specific drugs unless SGLT2 inhibition and incretin don't prove to be effective. So let's start with these drugs, wait for 1 year, 1.5 years, and if the liver phenotype doesn't change, then it's worthwhile going to specific drugs like resmetirom, that's now approved, but certainly very expensive. And then in the future, if approved, FGFR21 agonists that really are very effective in particularly of reducing fibrosis. But for type 2 diabetes patients, SGLT2 and GLP-1 based therapies are actually on the table. And then is the point, what about those people who don't have diabetes, so don't qualify for SGLT2 inhibitors, are not really obese, don't qualify for GLP-1 therapies. So in those with MASLD and fibrosis, MASH and fibrosis, here resmetirom would be the first-line drug, or semaglutide. So that is then being used specifically for these people.
And Norbert, to bring us back to the theme of the Diabetes Symposium, is there one thing you would like clinicians or people living with diabetes to understand about MASLD as a complication of diabetes?
Yes, and that's the observation of a meta-analysis where people were in 6 studies were followed up for a mean of 3.5 years and a total of 7 years. So in these 6 studies, people at the beginning of the observation all had MASLD, and they all underwent magnetic resonance elastography and had quite some fibrosis. And what happened during the mean of 3.5 years is that people with diabetes had 3.5 increased risk of hepatic decompensation and about 8-fold risk of hepatocellular carcinoma. So starting with the same or very similar histology of the liver, diabetes patients are on a completely different track. So their progression to hepatic decompensation, particularly hepatocellular cancer, is immense high. And then when the authors did a correction, adjustment for fibrosis, so everybody expected that it is driven by fibrosis, also in those people with diabetes. Fibrosis measurement did not explain all of the high risk in diabetes. So the result for our people or our physicians treating patients with diabetes is, if you have a patient with diabetes and MASLD MASH, you can be sure that this person is at the highest risk, maybe only similar to people with extreme alcohol intake or severe viral hepatitis, but this person is on a complete different track. And if you don't treat the diabetes, the hyperglycemia, the subclinical inflammation, and dyslipidemia, if you don't treat this well in these patients, they will be at a much higher risk than a person starting with the same liver phenotype but not having diabetes. So diabetes and MASLD MASH, this person is the highest risk patient for liver disease progression.
Norbert, that's great. Thanks so much for helping us understand why fatty liver may be more than just a passenger in metabolic disease, and why we need to start thinking about MASLD as a complication of diabetes and how to screen for it. Before we let you go, where can our listeners follow your work? Is there a lab page, an institutional page? Are you on the social medias?
Yeah, so I'm on LinkedIn, where there is always we have interesting findings. Then we have our institution page where people can contact me, and certainly when there is interest for collaboration, I'm very happy. Just if people send me an email, and then there's a possibility of doing collaborations and giving advice.
Nice. And I'd also point our listeners to your article titled MASLD is a Complication of Diabetes. It's out in this month's issue of the Journal of Diabetes. And currently, listeners can watch your talk at the ADA Diabetes Symposium on demand at ada.org. Thanks so much for joining us.
Thank you, Kevin. Thank you, Darlene.
Great to have you.
All right, we've heard from experts talking about the liver, talking about the heart. Now we're turning to something that most people experience from time to time and may not immediately think of it as a complication of diabetes, and that's infection. Our next guests are Professor Julia Critchley, Professor Tess Harris, and Dr. Liza Bowen of City St. George's University of London. Together, they bring perspectives from population epidemiology, primary care research, and frontline general practice. Their team linked primary care, hospital, and mortality records to examine infection risk in more than 800,000 people with type 1 diabetes, type 2 diabetes, or prediabetes, together with more than 1 million matched individuals without diabetes. Their work asks whether infection should be considered alongside cardiovascular disease, kidney disease, neuropathy, and other complications we routinely associate with diabetes. Julia, Tess, and Liza, welcome to Sweet Talk.
Thanks for having us. Thank you. Looking forward to talking to you.
Now, before we get into discussing this research, we usually like to start off with a little bit of an icebreaker question. And I have a little bit separate one for each of you. Liza, we'll start with you. Just curious, outside of work, are there any hobbies or interests that help you reset, recharge, give you more energy to get back into the clinic?
Yeah, so I spend a lot of my time playing a sport called Ultimate Frisbee, which over
Nice.
here in the UK is considered a bit of an unusual and niche sport, but is, from what I understand, much bigger over in the States. So yeah, we enjoy doing tournaments with people from all over the world. And when we travel, it's a nice way to meet people. It's a really nice community.
Yeah, that's really cool. I've seen some people participate in that. The only thing I've done with Frisbee was Frisbee golf, which is not quite the same level of energy that you're doing with your Ultimate Frisbee.
So a lot of people retire into Frisbee golf. It's a it's not a cool version, but maybe one day that might be where I'm headed.
Are you calling me old?
No, that wasn't the intention.
Yeah. And Tess, what first drew you to primary care research?
Okay, thanks, Kevin. So it really goes back to when I started off as a GP, so early 90s. And I was really aware that a lot of the things that I was reading kind of in research, or the guidelines that were sent to us about what we should be doing in managing our patients, weren't really coming from primary care. They were all coming from hospitals, so either secondary or tertiary care. and they didn't seem really quite so relevant to the patients in front of me or the problems that we were grappling with. So I decided I wanted to kind of go and train in epidemiology research methods and actually do a bit of both, bit of practice and also research. And it's really taken off now. There's so much primary care research. It's fantastic. Yeah.
Yeah, it's really great. I mean, being able to take those observations in the clinic and apply them to maybe back to basic research or onto epidemiology. And so it's really great that you're going down that line of investigation. And Julia, what first drew you to population health research?
Initially, I did a PhD, which was actually in a biology department in population biology and ecology. And kind of through that route, I realized that the sort of methods that we were using and what I was training is actually quite similar to public health and population epidemiology. So I came at it through a sort of slightly sideways route, realizing that there was this additional branch that affected, first of all, is thinking about the health of animals, but actually the health of human populations as well. So I came at things from a different angle, thinking about a whole population approach to health and prevention, and realizing that there were other ways of trying to achieve that weren't simply working with individual patients, which is what you tend to think of more as medicine. And that was sort of in the early 1990s when I was still quite young. And then I retrained in population health, public health and epidemiology after that.
Yeah, and that brings us into the study, I think, looking at population health. When most of us are hearing the phrase of complication of diabetes, we think about cardiovascular disease, kidney disease, neuropathy, eye disease. Infection feels different because everyone gets infected or gets infections, whether or not they have diabetes. What makes infection a complication of diabetes more in a big picture rather than just a simple common event that also happens to people with diabetes? And I guess why has it received so much less attention than traditional complications?
That's a really good question, but I think you've partly answered the question. It's because infections are seen as being common. They're seen as being mostly mild in all groups in a population. They're generally treated in primary care, don't necessarily need an infection. But when you look at people with diabetes, this isn't always true. And it misses the fact, for example, that in one of our earlier research projects, we found amongst people with diabetes, 20% actually had a more serious infection requiring hospitalization, over a 5-year period. So they're much more common than people realize, and actually very uncommon in people without diabetes, as long as they're under the age of, say, about 50. So younger people without diabetes really don't have those kind of infections very often at all. So they are very characteristic of diabetes. And to answer that, maybe from more of a clinical angle, when you think about some of the serious infections, bone and joint infections that we think of being as signal infections for diabetes, they're actually much more common, 20 times more common in people with diabetes to those without. So I think it's the fact that the relative risks are quite high. They're a lot higher in people with diabetes than people without, particularly at a younger age. The severity is high. And this is actually across the board, not just in the infections that people tend to think about as being most strongly related to diabetes. So almost every type of infection is way more common.
And related to this study, the examination of the hospital records, can you give us a basic shape of that study and design and explain, I guess, what linking the primary care, hospital admissions, mortality records allowed you to see that any maybe one source alone would have missed?
Okay, so the primary care aspect of it meant that we were able to pick up on a whole population, even minor infections, so minor and kind of slightly more severe infections, all of those that were treated with antibiotics in a primary care population. So that gave us a big strength looking at it at a population level. Adding in the hospital admissions meant we really were able to look at the severe end, those that led to people spending time in hospital for their infection. And then the mortality really at the very severe end, which kind of infections actually lead people to dying from an infection. So it meant we could go across the whole spectrum and be really comprehensive in what we were looking at. Liza would like to add something, I think.
Well, I was just going to say the other thing is that the primary care data that we have is really rich in terms of giving you background information about the patients, in terms of what their comorbidities are, a lot of measurements of things like HbA1c, so glucose control, but also some socio-demographic things. So you can get a measure of deprivation. We had very good recording of ethnicity, which was important for this study. So the primary care data is very, very rich in a way that you can't get at if you're just using the hospital data or morbidity data or mortality data.
And I guess what did y'all find? You know, when you compared the infection risk in people with type 1 diabetes, type 2 diabetes, and pre-diabetes with matched people without diabetes, what was the outcome?
We'll go through some of our outcomes quickly here. So just to summarize, we found that amongst people with type 1 diabetes, they were twice as likely to have an infection requiring treatment in primary care and 3.5 times more likely to have a hospital admission for infection. That's compared to people of a similar age, sex, and ethnicity. They were with a matched control group. So for type 1 diabetes, that's really a lot more common. For people with type 2 diabetes, they were about 1.5 times more likely to need treatment for a infection presenting in primary care, and about twice as likely to be treated in hospital. Then we also looked at people with pre-diabetes, which hadn't been assessed very much in previous studies. And what we found was that really risk is on a continuum. So obviously people with pre-diabetes already had an increased risk of infections that we could identify, although this was somewhat lower. They were about 1.33 times more likely to have an infection that needed treatment either in primary care or hospital admission. So in terms of other key findings, what we found was that amongst people with type 1 and type 2 diabetes, those at younger ages had higher relative risks, and that's partly, as I suggested earlier, because infections are not very common in younger people without diabetes. And we also found that particularly amongst people with type 1 diabetes, those of non-white ethnicities, in the UK, that's mostly South Asian populations, but also Black and Afro-Caribbean populations had higher infection risks as well. In type 2 diabetes and pre-diabetes, this was actually fairly similar across all ethnicity groups. There weren't large differences.
I was curious, though, as it related to these infections, you know, the estimates I think I saw listed were about 6% of primary care infections and 10% of infection-related hospitalizations across whole adult populations you found were attributable or statistically attributable to type 2 diabetes or pre-diabetes. And I'm just curious, for somebody that's not in the field of epidemiology and don't routinely work with attributable risk, how should those individuals understand the importance of those numbers and how significant of a contribution this risk could be for infection, hospitalization, and more severe outcomes?
Yeah, so it's Julia here. I'll just to summarize, I guess the way of thinking about it, you mentioned risk for the individuals, but this is risk for society as a large. So what's that telling us is really, if you think about the whole population, and we're fortunate in the UK that we have data sets like primary care that are very generalizable to the whole population that enable us to do this. What we're actually saying is this is the proportion of infections in the entire population, both people with and without diabetes, that are potentially preventable if we could somehow avoid diabetes. So it's quite a high proportion because it applies to everyone, including people that don't even have diabetes. It tells us, if you like, what the sort of resource use. And that's really the reason why we found the population attributable risk was higher in people of non-white ethnicity, because they have about a 3 times higher risk of having diabetes in the first place than our white population. So that wasn't so much a difference in the risk of infection, but in how common diabetes is. So it's a big problem in South Asian communities in the UK, but that's because diabetes is very common in those communities.
Yeah, I think it's really interesting because I think, I'm not in this field of epidemiology research, but it should translate to approximately 1 in 17 primary care infections, maybe 1 in 10 infection-related hospitalizations across that population could be attributable to diabetes, type 1, type 2, maybe even prediabetes. And so when you're thinking about the number of people that could be affected by this, that's quite interesting to put it into that perspective.
We didn't include type 1 diabetes in those estimates because type 1 diabetes is not a common condition. So it was just the
Okay.
people with type 2 and pre-diabetes. But yes.
Yeah, and it's also interesting you bring up the Asian population, just the incidences of diabetes in that population being much more common. And diabetes, pre-diabetes can be quite a difficult condition because it's not necessarily something that's diagnosable by looking at somebody. Many people walk around with pre-diabetes and are completely unaware. So the amount of people that could be affected by this is quite interesting. Now, the glucose effects that Tess had mentioned earlier, I think it could be interesting to get into the effect of glucose variability on the infection rates that you were seeing. And so I was curious if you could discuss more about that aspect of diabetes and the glycemic control contributing to the infection risk.
Okay, so I'll start with this, but do jump in. So we looked at two different measures of sugar level control. One was HbA1c actual level and how high that was. So that measures your average sugar level over a couple of months. And we looked at how high that was in people. We look at measures before we looked at the infection. So it predated the infections that they had. And the second measure we looked at was how much your HbA1c varied, so how much it went up and down. So the first one was kind of an average of it, and the second one was about variability, how much it bounced around in individuals. And we related both of those measures to the number of infections that people had. And we found that both of the measures were strongly related, but there was a bit of a different picture in type 1 diabetes from type 2 diabetes. So in type 1 diabetes, we found that really the thing that was most strongly related was how high the HbA1c level was. The variability was also related, but it wasn't such a strong predictor in type 1. And we think that that might be because in type 1 diabetes, there are quite a lot of people who have measures across the range of HbA1c, including some with quite high average level measures of HbA1c. In type 2 diabetes, we got a bit of a different picture. So again, both the average level and how much variability there was related to infection outcomes. But the stronger predictor was actually the variability level. So even people who had kind of quite good measures of average HbA1c, if there was actually variability within that, that would still be a strong predictor of infection outcomes. So for type 2, it seemed like the amount that the HbA1c was varying over time was a stronger predictor than just the average level.
And I'm curious with this study, many of these individuals were likely on some kind of a therapy or treatment. Was there any evidence for specific therapies holding that variability of HbA1c within a tighter range and limiting that variability and potential outcomes as it related to infection risk? The incretin drugs that are coming on the market or on the market, highly effective. Just curious if you found anything related to that.
Yeah, it's an interesting question. We didn't actually delve into individual kind of therapies, and that would be something that we'd be interested in doing going forward. Our data set actually went up to 2019, and we kind of stopped it for the COVID period because that introduced all sorts of complexities about diabetes infection outcomes and things because people weren't presenting in the same way to primary care or to hospitals. So actually, in terms of the therapies that you've talked about, they're much more prescribed much more recently. So I think that's a really interesting question that it would be really good to look at within a more current data set, and we'd be interested in doing that in future research, but wasn't something we looked at in our data.
Looking back now, is COVID timeframe something that you guys might be taking into consideration on a future follow-up study for the risk of COVID infection or the severity of outcome as it relates to these different states of diabetes, pre-diabetes, type 1, type 2?
There was lots of data on COVID and infections, and it's quite difficult in that period to look at other infections because we realised that the way primary care and also hospitals were responding to other infections was very different, and obviously their rates of infection of other things went down because of a lot of the measures of isolation and things that occurred in. So it's a very complex area, and other people had looked at it in relation to diabetes and COVID. So
the other interesting thing I think is that the pattern of risks associated with diabetes and COVID is almost identical to what we found for diabetes and pneumonia. So perhaps at the end of the day, that suggests it's a kind of general mechanism, and COVID pneumonia wasn't really any different from other viral or bacterial infections that cause pneumonia in the way.
I guess what did happen in COVID was it sort of highlighted the importance of infection in a way that people had maybe thought about less previously.
It has definitely highlighted the importance of infection, and people understand that better. So certainly in the UK, and I doubt it was very different in the US, up to about a third of people in ICU with COVID did have diabetes. But I think we'd have to make it clear it doesn't come from our own research. Yeah.
And the other aspect of your research, you looked at BMI and how that was associated with infection, and found that the curve rose sharply at high BMI, which may be expected, but it also rose again at the low BMI with this U-shaped curve. I'm curious, a little speculation about the low end of the BMI. Maybe trying to resolve a mechanism. Could that low BMI be marking frailty, undernutrition, low muscle mass, any variety of conditions there? Maybe rare conditions such as lipodystrophy were taken into considerations, or other forms of lean diabetes in the database that might be contributing to that infection risk. Just speculation. I don't know. Did y'all find anything on that lower end?
There's a couple of comments that I'd like to make about that. First of all, everyone's intrigued by that low end of the spectrum because it does seem to increase very sharply once BMI falls below about 19. But I want to bring people back to the population health perspective again initially, because those low BMIs were actually very uncommon in our data set. They're not very common at all in people with diabetes, and they're not particularly common in people without diabetes. So although that pattern is interesting clinically, at a population level, what's important is elevated diabetes. And there were other infections. Elevated BMI. Yeah. What is important is elevated BMI. And for other infections like skin infections, cellulitis, which are very common, those with the highest levels of BMI had about 6 times higher risk of diabetes. And there were just a lot more of them in both the UK and the US than those individuals with very low infections. So that's the first thing to note. What we did see, though, that's quite interesting is that amongst those with very low BMIs, there was a quite substantially elevated risk of infections. And this is particularly people with pneumonia and sepsis. And I'm sure you're right, it's driven partly by comorbidities and frailty. We think about older, frail people, for example, being those that are most likely to die of an infection. And we know from our own data that pneumonia has often been a common cause of death in older people. But what we thought was interesting was in our data set, we actually did repeat our analyses. We performed a number of sensitivity analyses to try and understand this better. And in one of them, we actually, in the data set, in one sensitivity analysis, we repeated our analysis, excluding people that had any of a long list of comorbidities, which is all those on the QOF, Quality and Outcomes Framework. Can you list what all those were off the top of your head?
Common chronic conditions.
Very common chronic conditions.
Heart disease, respiratory disease.
Yeah, it's a list of 12 things.
Yeah.
There's a list of 12 things that are common. So and also people that had ever smoked, because smokers are also obviously different in terms of both their BMI, they tend to be lighter, and their risk of infections as well. And even after we'd done all that, so we tried to get this group of people that were as healthy as possible, if you liked, had no comorbidities other than their diabetes and had never smoked. And we saw exactly the same pattern of risk. So we don't fully understand it, but it can't be just due to frailty or comorbidities or smoking.
Nice. And I think to wrap this up, the findings that you're describing make a strong case that infection is not simply a minor accompanying problem. If infection belongs on a list of major diabetes complications, what do you think needs to change in clinical guidance or routine care?
So I guess thinking about the guidance level, so at the moment, our NICE guidelines, which are our sort of UK clinical practice guidelines that we follow, only really mentions infection when you're thinking about type 1 having diabetic ketoacidosis or in kind of foot complications, which is the more like commonly recognized infections. But I think probably just putting it up there with the other more commonly recognized complications that you touched on at the beginning, so heart disease, retinopathy, neuropathy, kind of just sets the scene. And then I think going to the individual level when we're talking to patients, I mean, many clinicians may do this already, but something that we found from talking with our patient and public involvement group is that bringing infections when you're discussing potential risks and complications from diabetes can be quite a motivating factor, because it's potentially much more immediate than thinking about things like heart disease and stroke that people sort of think of as far into the future. Whereas if you're thinking about trying to get your diabetes under control to prevent infections, that's a much more immediate thing for people to focus on. And we found that people could really resonate with that as something to work on and help improve their control. And then I guess thinking about access for patients, so making sure that people know they need to really take infections seriously and try and present early to healthcare, so that they're not letting these infections get worse and worse and get to the point where they do need a hospital admission, or at the most severe end of the spectrum that we looked at, obviously death from infection. And then obviously that's not just on the patient. So from a clinician's point of view and a general practice point of view, we need to make sure that when we're triaging patients that we're not making it difficult for them to get appointments. And one of the things that we talked about was that as clinicians, we're sort of balancing priorities, and there's obviously a drive not to overuse antibiotics to try and prevent antimicrobial resistance. But that's obviously nuanced and we need to consider the sort of risks that we've found in patients with diabetes to make sure that, we get that balance right.
I think the other, I think that's really helpful looking at all of those aspects, but the other aspect is thinking about preventing infections with immunization as well. And shows really powerfully how important taking up the offers of immunizations like your annual influenza vaccination, the pneumococcal vaccination that everyone with diabetes should be offered, making sure everybody really understands that these infections are common, and the severe infections are not rare either in diabetes, and that it's really powerful to have all the protection in terms of immunization that you can to help prevent them.
That's great. Thank you, Doctors Julia Critchley, Tess Harris, and Liza Bowen for joining us today. For our listeners, their team's companion article, Increased Risk of Infections in People Living with Diabetes, appears in the Journal of Diabetes this month. as part of the 2026 Diabetes Symposium collection, and you can view Julia's talk from the ADA scientific sessions streaming on demand now. Before we all let you go, where can listeners follow your work? Is there a lab page, an institutional page? Are y'all on the social medias?
All of us can be followed on LinkedIn.
Yeah, that's probably the best place to find us all.
Perfect. We'll look for you there. Thanks again for joining us. And to our listeners, please like, follow, and subscribe for more Diabetes Bio content.
Thanks to all of you for joining us on the Diabetes Bio podcast. We hope that you're enjoying our discussion of the work that the Diabetes Journal is publishing each month. The feature articles we discuss in each episode are freely accessible at diabetesjournal.org/diabetes and are also listed in the episode notes for your reference. As with any podcast, it really helps us if you like, rate, follow, and subscribe to the podcast. And if you have any feedback for us, we'd love to hear that as well. We look forward to presenting to you each month.